Good afternoon, and welcome to blackdoctor.org. I am Ellis Dean, a senior project manager with blackdoctor.org, and I'm very excited to be with you here today. One of the most interesting things about living in the middle of a pandemic is that so much of attention has been placed on the virus and the vaccine and the distribution of the vaccine and who's going to take it and who's not going to take it, and it has really kind of taken a lot of our attention and energy away from other things. So healthcare disparities have been discussed, but it's kind of been discussed in the context of the virus. And so but what about those other illnesses? There are still other illnesses didn't go away just because there's a pandemic. So we've got to make sure that we are focusing on a lot of other illnesses, especially those that are disproportionately affecting our community. So, because those illnesses are going to still be here once we get COVID under control. And if we don't pay attention to them, they could worsen over time. And so we got to make sure that we're putting in the work and giving the time to those particular illnesses. So today, we have a special guest who is on the front lines of fighting healthcare inequality, which we all should be able to do on our own way. But he's on the front lines of fighting healthcare inequality, particularly the relationship between heart health, diabetes, and specifically amputations. And y'all know that especially diabetes is very high in our community, in the Black community, and amputations, unfortunately, have become a result of improper care of a diabetes, and he's going to talk about that better than I can. But the thing that we do have to recognize and understand is that some of those amputations are unnecessary. And so that is what we're going to talk about today. How necessary are these amputations and what we can be doing to ensure that ourselves and our loved ones aren't receiving an unnecessary amputation. So all of that. So today we're going to be talking to Dr. Faluso Fakorene. I think hopefully I said that properly. He's a wonderful man, a great doctor with a lot of energy. And we are, but let me give you his background. He specializes in preventative cardiovascular management, women's heart health, and catheter-based procedural focus on coronary arteriosclerosis. I had that practice, but I didn't get it right. Disease and peripheral arteriosclerosis disease, PAD. He currently serves on the Society of Cardiac Angiography and Intervention, Vascular Disease Committee, and he's also the co-chair of the Association of Black Cardiologists PAD initiative. And so there was much more that he had done in his career, but we wouldn't be able to have our interview if we had talked about everything he has done in his career. So what I'm going to do now is I'm going to play a short video about him and his work, and then we'll come back. We're going to have a live conversation with Dr. Fakorene. Thank you, and stick with us.
Over the past 3 years, we have had an interesting outcome in terms of raising awareness and talking to people at the level in which they can understand it from both an educational standpoint, clinical standpoint, and scientific standpoint.
We started realizing that we had to go out to the people. If you don't know you have a health problem, you're not going to seek out care. If you think your leg pain is due to arthritis, you're not going to seek out a second opinion or more treatment. So Dr. Fakorene realized that if you go to the churches, you can get people. Everybody goes to church. And we live in the Bible Belt, and that is the focal point, that is the drawing point for everybody.
Good morning. Please stand and help me welcome our newest health ambassador of the Mississippi Delta, Dr. Faluso Fakorene.
Good morning, family. Good morning, everybody. How y'all doing? Good. Thank you. Just want to start off by thanking everyone for bracing the elements of the weather today to come out to listen to this important message. I've decided to target faith-based organizations because in a faith-based setting, majority of all stakeholders, when it comes to it being a provider, it being a family member, it being a politician, or a community activist all show up in the same setting at the same time, and they can understand what the risk factors are, what the treatment should be, when to seek a second opinion if you're told about an amputation, and who the best physicians or providers that will be able to treat the conditions. Atherosclerosis is the buildup of fatty cells, calcium, and other elements that leads to the narrowing of blood vessels to all the major organs in your body. So if you have narrowing of the blood vessels to the heart, you have coronary artery disease, heart attacks. If you have it going to your legs, you have peripheral arterial disease.
The idea that you have to wait for a patient to come to you is an old-fashioned way, or a way that's not going to work here in the Mississippi Delta. So we've made it our passion to try to get out at least once or twice a month out into the community and bring the word out.
So I've already talked about, things that we can do. That's why we're here today. We have Bart who's here to help patients look at the circulation now. Anyone who wants to get screened for it, you're more than welcome. Because screening is the preventative way to pick up this disease state early so that you do not end up with being a statistic of someone who's amputated.
It was interesting, a lot of the people that did come to get screened, these are people that are more proactive with their health. So some of those were negative, but as we discussed it with them, a lot of them would say, well, my mother had an amputation, my father had an amputation, my brother is having this problem. And Dr. Fakorene's coined the term being a community navigator, that it's going to take all of these people going out into the community and getting their word out.
And so Mississippi serves as the epicenter for this, and we've been able to reduce amputation rates by 88% by multiple pronged approach.
Well, I hope you got as much out of that video as I did, and we just got a little glimpse into our guest today. I just want to say that this brother has a heart, and he knows how to use it to help our community. So I'm going to shut up and let y'all meet the man, the myth, the legend, also known as Dr. Fakorene. How are you doing?
Mr. Dean, how you doing, brother? How are you?
I'm doing well. Do you get uncomfortable watching that video? Or
I do. First of all, thank you for the privilege of invitation. To you and the audience. It's an honor to come here and speak truth to power on, my why I'm here, why I do what I do, and to try and affect change in the process.
Well, great. Well, thank you for taking the time out. I know you're still seeing patients. And so just thank you for taking the time out to join us and help educate our audience. The first question is, I know I just read off all the stuff about what you do, and I'm doing the tongue twister thing on trying to say arteriosclerosis. But in layman's terms, could you please explain what you do to our audience?
Sure, absolutely. I am a heart and vascular specialist. I am an interventional cardiologist. So plain and simple, I'm the guy that when your arteries are clogged up, they call to unclog your arteries. Just as if your pipes in your kitchen sink were clogged up, you call a plumber. If your pipes in your heart are clogged up, they call an interventional cardiologist to place a balloon or a stent. And also, if that process happens in your lower extremities and your limbs, and you have poor oxygen flow going to your limbs, and you need someone to come and unclog that artery and unblock that blockage, you call an endovascular specialist, such as myself, to come and restore good circulation to the lower extremities.
Okay, wow. I guess the heart is the most important muscle in the body. I've heard that throughout my entire life, and so we've got somebody here that can help us keep ours healthy, whether it needs a checkup or not. So, what got you interested in cardiovascular medicine?
It's a great question. When I was, if I recall, when I was 5 years old, my mom is a registered nurse, and I grew up in Nigeria and West Africa. And after school, every day we would go and see her at work right before we, hitched a ride home.
And in just observing her interaction with this one particular doctor, and he commanded the presence and attention of the whole team that worked with him, particularly nurses and some technicians, and had a great bedside manner and was looking dapper in his three-piece suits all the time. And I'm like, Mom, what does he do? Well, he was a heart surgeon. So I told my mom that I was going to become a heart surgeon at age 5. Well, that's not why I became a heart specialist. Well, as time progressed, I developed this keen interest for science, and then I developed a passion and to interact with people. You know, medicine encompasses the power in mankind to do good, to heal, and to be humanistic. But you have to have a passion for science, and you have to be good at it. So kids study those books. Yeah. And then I knew I was good with my hands in the dissection class, in the dissection lab in high school, and then I one day went into a lab and saw what interventional cardiologists did, and I came out and I said, well, I'm not looking back, because I can do basically cutting technology to see the academic and scientific results of restoring blood flow to someone's heart or your limbs instantaneously. And so that patient comes in pain, but goes home, free of pain, and alive. So that was what instilled my passion in the cardiovascular field, particularly interventional cardiology. And, I became a student of the work, the art, and the science, and here I am today.
So he said at 5 he's going to be a heart surgeon. I'm going to give you a summary of that. He said at 5 he's going to be a heart surgeon, and today he's a heart surgeon. Started with the suits and ended with the work. And so where we are today, so we're very, very happy. And from some of the comments I'm seeing that are already coming through, apparently you're a very, very good heart surgeon. And so, and what you're doing there. So, but many would say he's a heart surgeon. That's a very specific skill set that is high in demand. You can have a very, very comfortable life without having to get into healthcare disparities. You could go on and say, hey, look, I put in the work. I was disciplined. I got through medical school, got through my fellowship. I'm good. I'm about to go, live my best life and be a heart surgeon and not get involved in working in the community and healthcare and health disparities. What made you decide to add that on to what you're already doing in your regular job?
Well, to clarify with the audience, I'm a proceduralist, so I don't cut on people. I'm not a surgeon per se. I'm a interventional cardiologist. Okay. But my job are to use what we call minimally invasive procedures to work on folks and discharge them home so that they avoid the surgeons or the blade. But to your question as to why I ended up being committing myself to the most rural area or the epicenter of cardiovascular disease, the answer is just, God led me here. It's just that simple. And this is how. When I finished my fellowship, and shout out to, where I was trained in New Jersey, from Robert Johnson Medical School to Cooper Hospital, and also New York Presbyterian Hospital, Weill Cornell in New York. When I was done, I came to the South because if you look at the demographic of cardiovascular disease, which is the #1 killer, 1 in 3 people die of a heart event that kills 700 to 800,000 people yearly. This is pre-pandemic numbers. Right. 50% of African Americans carry a risk factor for cardiovascular disease, 50%. That burden is predominantly in the South, which also carries the lowest number of limb preserving specialists and also the lowest number of heart saving procedures that are done. And you look at that disparity and you look at the outcomes and you see what is the underrepresentation of minority physicians that look like me who serve in a predominantly African American region. Well, Mississippi has 40% African Americans, but also has the lowest number of physicians per capita, but has the highest amputation rates, has the highest diabetes, one of the highest diabetes rate, obesity rates, heart attack rates, dialysis rates, all lead to cardiovascular outcomes that are very poor. So I challenged myself and I said, well, why not set a legacy trend for yourself and come here and see if you can do good work, engage the community, show them both your technical and interpersonal competence, but also to speak truth to power on some of the systemic and systematic issues that are pervasive in our field that lead to disproportionate outcomes in treatment, and also in the lack of preventative strategies that should be endorsed in such communities. So it was a challenge to myself, but also it was a mission from above to come here and see if I can affect change. And here I am.
Well, I guess what do you think? What do you think your biggest challenges has been in those in that endeavor? Say, I came to the South. I was in New Jersey for the first
Yeah,
time.
you know it. You know it.
Right in the South. I'm talking. We love ham hocks. We like
Man, sweet tea. Come on now. Don't get my audience started now. All right. Don't bum rush my clinic tomorrow and for jumping dogs. That is number one. The culture shock. I tell people there's Mississippi and then there's a Mississippi Delta.
Yeah.
And Chris Rock has an interesting tambourine in his stand-up where he explains Mississippi. Well, there's the Delta, and the Delta, when you come here, it's rich in culture, but also you have to understand that I was an outsider when I first came. Growing up in a Nigerian who then came to the States at a young age. It came to the States as a young teenager, and then ended up in New Jersey and New York. So I'm a Yankee per their standards, right? I'm an outsider, and I come here but I had to learn the culture and understand that that there were things that were still remnants of in the pre-civil rights era and post-civil rights era that are still pervasive today. Racism being one of them, and that was part of the challenge. Two, getting people to buy in as to what my mission was. My mission was to come here and set up a comprehensive cardiovascular clinic where you can come in and get everything evaluated for your heart and your vascular system, but also with an aim to decrease amputation rates. I wrote it down. I said I wanted to decrease amputation rates by 25% in 2 to 3 years. Well, fast forward 3 to 4 years, we decreased amputation rates by 88%. And so that engaged putting a team and a clinic together, which you're not taught in medical school on how to do. I became a CEO. I became the owner of my practice. I had to learn the discipline of how to be an administrator, a clinician, a community navigator, but also to fight the elements outside who were trying to see me not succeed for other reasons. And it's staying prayed up and believing that your mission is just and committed and persevering through in and throughout. So that's what it took.
Well, amen to that. Amen to that. So you are a cardiovascular interventionist. Okay, I think I got it right.
Yes.
But you talk about diabetes a lot. What is that relationship between heart health and diabetes?
Well, I'm sure folks something here. When you're born with clean arteries. This is a blood vessel, okay? Clean arteries. What happens is that as we get older, there are certain risk factors and certain behaviors that lead to the buildup of this waxy yellow substance that you see here in the middle that is called cholesterol. And it leads to the narrowing and the blockage that prevents oxygen-rich blood flow to this for this organ. So if you start from here when you're born to here, there are certain behaviors and risk factors that accelerate that process. Diabetes is number one. 2, nicotine use. But diabetes and obesity are our biggest challenges when it comes to addressing health disparities, especially when it comes to the cardiovascular outcomes. It increases your rates of heart attacks 2 to 3-fold. Diabetes itself increases your chances of getting an amputation 3 to 4 times. You have other elements in terms of your damage to the blood vessels that can occur. So those are things that you have to get addressed, and those risk factors have to be addressed early on because these patients present with bad outcomes, aggressive forms of the disease, and have severe complications from the disease, namely blindness, namely ending up on dialysis at a young age, having a heart attack at a young age, a stroke at a young age, or losing their limbs at a young age. So that's why we aggressively attack diabetes.
Well, great. That was good to know, because I mean, just from a lay person, when you think about heart health, you just think about heart attacks and hypertension. Those are the three
Right.
H's: heart health, hypertension, heart attack. You
Right.
don't really think about diabetes because that's the sugar, right? And so
Right, that's the sugar. Yeah, so the sugar and our weight are related, right? So because
right.
majority of obese patients have some form of diabetes, and if you look at patients who are obese as well, it has a relation to hypertension, and so all these things are tied in, and that's why we have disproportionate outcomes when it comes to hypertension, diabetes, obesity outcomes, and heart attack and amputation outcomes. So that's why we always preach, the number one preventable cause of death is our diet and what we do with our time in terms of exercise. Those are the two main key parts or components that I try to preach to everyone that I see.
So why do you think some medical practitioners and hospitals are more apt to amputate versus taking the steps to save a limb?
Whew, that's
Loaded question.
we got to go to church on this one, because that's the one thing I do. I just call it as I see it. It's unfortunate because if you look at our economy and what we do, like, you can talk about the clinical and evil of amputation versus the economic impact that has. So I'll tell you both. One, clinical. If you have peripheral arterial disease, it's slow, it's progressive, and it's deadly. And you are 6 times more likely to have a heart event that will lead to number one killer, which is cardiovascular disease. And 3, if it's not caught on time, you will undergo an amputation. If you're a diabetic, that is 4 to 6 times faster. But even if you're a non-diabetic and you have that as a minority, you're 2 to 3 times more likely to have a bad outcome. And the 5-year death rate from peripheral arterial disease is worse than breast cancer, colon cancer, and prostate cancer. So we do all fear cancer, and we have screening methodologies that are in place and policies in place and preventative initiatives. But we don't have that for peripheral arterial disease, which affects 21 million Americans, 200,000 of whom will get amputated. And 60 to 70% of those patients have some form of diabetes, majority of whom are minorities. And so when you look at practitioners, it's because they're not incentivized to screen these patients early on. There are no policies that state that we need to start screening these patients early on in the disease process, other than if they visit a vascular specialist such as myself or a cardiologist, do they get screened? But we are not the first line of defense for these patients. Most of them see just general practitioners or nurses and doctors in the community. And those doctors are not incentivized by their governing body to screen these patients who are at risk for amputations early on in the disease process. So it translates to the hospital. These patients are not taught about how to eat right, live right. They have social determinants of health that prevent them from, attaining equity in terms of, outcomes. And so they end up in the emergency room, and the hospital is incentivized to do procedures and surgical procedures on these patients. In spite of the fact that, an amputation itself is more costly than a limb preserving procedure that someone such as myself can provide, therefore saving dollars to the hospital. But hospital administrators are short-sighted. They don't get that. They don't see that. They are limited in scope because they are driven by what surgeons, and I'm not casting a blame on all surgeons, but predominantly in rural areas, these surgeons play a big role in how the hospital is run in medical executive communities, in terms of what power, that structure they bring in terms of to the CEO or CFO of the hospital, and they play significant roles. And so that is, antithetical to our Hippocratic oath as to do no harm. Amputations itself are one of the top 5 performed surgical procedures to date per Medicare data. and majority of these patients are minorities. And so they might profit early on in terms of the doctors, but the hospitals lose money. 90% of these patients never make it home after 100 days. And 80% of these patients will have chronic pain syndrome, and we have a chronic pain epidemic in our country.
Right.
50% of them will suffer from depression. 80% of amputees are dead within 5 years. 35% of amputations performed will need some form of revision within a year or two. And then you talk about the cost to the patient, that's a $500,000 lifetime cost. So if I tell you that Mississippi ranks #1 in amputations, and you look at the median income in this state, that's $32,000 to $33,000 per year. How can that patient afford that dollars? How can the family afford that? So you're looking at something that costs our economy $800 million a year to just perform amputations, but the healthcare costs are in billions, $30 billion a year. So for anyone who is either on the, politically speaking, if you are Democrat, Republican, or independent, there's one thing we should all see. The cost of our healthcare system is unacceptable. Why? Every single taxpayer pays 80% of that healthcare burden. So that $30 billion I'm talking about, you and I pay that bill. So we all have a stake in this. I mean, we can use a lot of that money doing something else, right? So that is why, we need to speak truth to power on this topic. And that's why we're having this discussion today.
Well, you just woke me up, because anything that we're overspending, we definitely got to find a way, especially if it's preventable. And I know we're talking and we're smiling, but this is a very serious matter, because we're overspending and we're engaging in procedures that aren't really necessary, and they could be preventable. So if you're just joining us, we're talking to Dr. Fakorene about the heart of the matter, and basically it's heart health and what he just talked about, which is unnecessary amputations, is particularly in African Americans overly amputated when they're having PAD, which I'm not going to try to say it again.
Peripheral artery disease.
Exactly what he said. We're talking about PAD. And so we're really trying to break it down and move to the next level. So before I ask the next question, I guess I just want to ask you, do you think that situation is more about race, or is it about socioeconomics, or is it about kind of the mixture of the two?
I'll let your audience decide, but it's called the social determinants of health, right? So a lot of health inequities in America are not only due to the health access component in terms of health coverage, provider, linguistic and competency levels, access to quality care, not just access to care, but access to quality care. So you go see a doctor who wants to save your leg, not see a doctor who wants to chop off your leg, right? You both had access to some form of care, but quality is what's life preserving. And then lastly is to make sure that, okay, let's address education inequities. Do the patients who I see understand what's going on? What's their literacy level? What is going on in terms of income and wealth distribution in that community? Can they afford them the bills that they're getting, right? Can they afford the copays to even go see a practitioner? What is transportation? So that physical and environmental neighborhoods. Transportation being one of them, access to go out to a park to walk when the doctor prescribes 150-minute a week prescription, right? Go walk for 150 minutes, in a week, and have some form of moderate activity that will ultimately decrease your heart attack and stroke and amputation rates. Well, I can't do that in a neighborhood if it's not accessible. So combine that with food deserts, access to healthy foods. Let's put all that together and then put the social context that we all face. You face it, I face it every day. It's discrimination, it's biases, implicit or not. And then, it's engaging that community and cognitive dissonance. Combine all that in a pot, that's called social determinants of health. That's 90% of the problem. And here's the other thing, right? So there's something called the amputation lottery. The amputation lottery is what determines what gives me a higher chance of getting amputated in America today. The following. 1, if you're older. 2, because with the fastest growing population of octogenarians, people in their 80s, y'all, and most of these people are seen by doctors who blame most of their pain in their lower extremities to arthritis or some gout, or as we call it here, the gouge. And they fail to recognize that it's poor circulation, and that neuropathy is actually might be due to poor circulation. The other thing is that we have race. Majority of patients who live in the South, the Black census scope of America, also are the ones who are least likely to be given what we call revascularization or angiogram, which is basically an X-ray with shooting an agent that will identify that blocked artery, and I can go in and unclog that artery immediately. It's called revascularization. 90% of patients who undergo an amputation in the state of Mississippi do not have a chance of undergoing an angiogram with revascularization. They're just chopped off immediately.
Wow.
The national average is about 50 to 60%. In spite of the fact that the odds of decreasing the amputation by performing that procedure is decreased by 90%. Imagine that. That is criminal. And then, if you're poor, if you're a Medicaid recipient or uninsured, you're more likely to get an amputation versus someone who has Blue Cross Blue Shield or commercial.
Yeah.
So and then if you're a minority, Hispanic, Native American, or Black versus if you're white. So those combination and your income status, if you make less than $35,000 a year versus if you make over $90,000 a year, those are things that determine if you get amputated or not. Your geographic location, your sex, your age, your race, and then the hospital volume. What is the competency of doctors in the hospital that understand peripheral arterial disease? Because the awareness in the community is very, very low. You and I can barely say the name of this disease. 21 million people, but only 1 in 4 Americans have ever heard of this.
Right.
And so that's why this forum is very important, because at the end of the day, the mission is just to raise awareness and to let you know that grandma's leg that got amputated should not reflect that mom should get amputated or you and I should get amputated. It's an intergenerational scar that we need to stop and we need to address now.
Man, I'm about to run out and just start doing
Come on, man, let's go.
Let's go do it. So that's a lot in that big pot that you threw. I mean, a lot of context is thrown in there, and I appreciate you providing all that context for the social determinants of health, because a lot of we try to reduce it to one thing, and it's the interaction of all of those things you talked about in that one pot that create that social determinants of health gumbo, so to speak. Talk about a pot. So what can Black patients do to avoid unnecessary amputations? What can we do?
Good. So the first thing we need to do is, one, we need to know that, in 2021 and beyond, we're sick and tired of being sick and tired.
Amen.
So when we walk into any office and we're being told that they need to chop off our foot, the first thing we'll say is, you know what, you might need a second opinion. That's the first thing. The second thing is to say, well, whenever you walk into any of your provider's office, if you have the following risk factors, you need to tell them to take off your socks and check your feet and put their hands on your feet to check the pulse of your feet. So who are these patients? Anyone over the age of 50 who has had a history of diabetes or nicotine use. So that's one thing that some white folks don't understand. And let's take them to church now, all right? Not every Black person smokes cigarettes, all right? Most people actually in the South do what? They've had, grandma or grandpa when they're young will give them, tobacco, as they call it. It's tobacco, but they say tobacco, right? They chew and they dip. So, and they've been doing it since they were young ages. So you need to ask them, not, hey, do you smoke, ma'am? No, have you had any nicotine exposure? Dip, chew, vape, you name it, because that increases your risk for poor circulation by 2 to 4-fold. The next thing is, if you've had a history of a heart attack or stroke, you need to get screened. If you've had kidney disease or on dialysis, you need to get screened. If you've had high blood pressure, high cholesterol, you need to get screened. And then if you have a family history of anyone who's had an amputation or been told that they've had poor circulation, they need to get screened. And how they get screened is first taking their socks off, checking their pulses with your hands, and 2, requesting for some kind of assessment that determines the blood flow and if there are any chances of you having a blockage. And if they tell you that there's no specialist around and they need an amputation, you know what? Next thing you should do is maybe write an email to padadvocate@gmail.com, and we'll find someone in your area for us, because that is just unacceptable in 2021, where limb preserving strategies are not the first offered, particularly to people of color. Rather, amputations are the first procedure of choice that are offered, and that has to just stop. It has to end.
Amen. So that was PA.
Secondly, is we have to be on the preventative side now, y'all. Just because we're talking about amputation doesn't mean that we keep on drinking sweet tea all the time. No, we got to cut out that sugar. All right, sugar is the new tobacco. We got to cut it down. Drink water. All right, mind, body, and spirit. All right, we have the heart. Right, we want to give our heart to God, but God wants us to have a healthy heart too. So, church folks, right, we need to understand that we need a healthy heart. And to have that healthy heart, you have to live right. You got to eat right. You got to watch that salt. You got to watch your blood pressure. You got to watch, your cholesterol. We got to take the medicine, be compliant. And, if you have any issues, if you got sleep apnea, you call the hogs, you're snoring, you got to get that treated. All right. Because that will decrease your blood pressure and make you exercise better. Right. So there are a lot of things we have to do on the front end to be preventative, but also on the back end to know our rights.
Amen to that. Man, well, I should have been taking some notes, but I got the video, so I'll watch this later. So, are there any warning signs? Can I, if I'm having some pain and it's not specifically in a joint where I think that's typically where arthritis, resides. If I'm having some pain, what are some things that I can notice about my own body that I can be my own kind of advocate and say something's not right? I need to go see somebody to get this checked.
Those are great questions. Those are great questions. I mean, one is I tell people if you get tired, there's not necessarily just pain in your lower extremities or your feet, but if you just get tired walking, or you have that restless leg at night, and it's like you have that numbness and burning that goes down your foot, and you've been told you got neuropathy, and you're on like all these neuropathy medicines, you need to have your circulation assessed, particularly if you're diabetic. 2, if you've had any pain or stabbing discomfort on ambulation, so when you walk in your feet, on your legs, you have to get your circulation checked out. If you have colder or cooler extremities, right? One foot is cooler than the other, or you just cold a lot all the time in your lower extremities, and you're cramping, you need to get your circulation checked. If one foot is darker, discolored, or your toenails, you got those toenails, they're just like getting yellow on you, and they're just looking off, Yeah, like we got to get that circulation checked out.
Don't go to the nail salon. Go to the
I know, right? That's a good idea. Actually, I'll go start dropping off cards there. And then it's also trying to make sure that if your hair growth, man, or for men, you realize that hair growth in your lower extremities are just not what they used to be, or it's just diminished severely. That's actually a sign of poor circulation. And in addition, for other men, is if they have forms of erectile dysfunction, that is a sign of poor circulation. So that's kind of, things that have to get addressed, where you need to see a vascular specialist such as myself.
Let me just say that for the record. That's hair growth in your lower extremity. So me and Dr. We're part of the beautiful bald men.
No. We're good. We're good up. We're good up here, man. We're good up. We'll keep MJ proud. We'll keep MJ proud. Yeah. No, we're good. We're good.
So that's fun. So they got some questions. So we're going to wrap up my questions, and then we're going to get to some questions from the people that
absolutely. Yes, sir.
So can problems like blockages and narrowing be reversed? I know you put in stents and other things. Can they be diet, exercise, anything that we can do to reverse those?
Yeah, unfortunately, when you start, father time is undefeated. So when you go from, having clean vessels to having plaque buildup, the best thing I can do at some point is to reduce this burden. I can go from this to probably this. But in terms of giving medicines to reverse that process, we don't have a drug that melts it away. We just have lifestyle and dietary modification that slows the progression of that plaque or that waxy substance called atherosclerosis. So the goal is to diet, exercise, right? And if you have your sugar, keep your hemoglobin A1C, which is a content of what your sugar has been for months, by checking the sugar on the protein. The hemoglobin A1C, every diabetic should know that number, and keep that number less than 7. You want to make sure if you have blood pressure, keep your blood pressure less than 130/80. You have to make sure that you have cholesterol, keep your total cholesterol at a low number, especially the bad cholesterol called your LDL should be very low. Less than 100 for a regular patient and less than 70 if you've had heart events or peripheral arterial disease or stroke. Take your medicines, and then also make sure that you have ability to see a nutritionist or seek for a specialist who specializes in whatever they can get controlled. Because a key component to this is that, especially in rural areas, there's the lack of specialty care. And what you find is like a state like Mississippi that has the third highest or second highest diabetes population, we only have a handful of endocrinologists, less than 10 in this whole state.
Mm-hmm.
So, that balance, and some of them don't take Medicaid, which, unfortunately, the Medicaid expansion was not taken. The Affordable Care Act was not adopted in this state. So we have hundreds of thousands of African Americans that are uninsured, so they can't even see an endocrinologist. Therefore, they're at home with diabetes, and they end up with the end stage, and they go to an emergency room to seek help when it's too late. It's kind of the analogy I use is that imagine if you have a sister who goes to get evaluated for breast mass, and immediately the surgeon says, we're just gonna perform a mastectomy without an ultrasound or biopsy.
Right.
Such violation is unacceptable. And the same thing with your limbs. So try and catch that cancer early on. That's the analogy. Is you want to make sure that you catch it early on, and you go see a specialist who wants to save your limb, because in doing so, you're saving your life. And also, it decreases your chances for heart attacks, strokes, and death.
Man, that's such great information. Before I get to questions from our chat room, which they've been putting in here, they love you, by the way. I think there might be a couple of marriage proposals over here. But so what's next for you? What's next for you? I know you're in Mississippi. What's the next? What would you like to see? Where do you see yourself in 5 years?
Well, that's a great question. I'm going to be here in Mississippi because, I represent less than 1% of the medical community in terms of being an African-American, Black, endovascular interventional cardiologist. So I am one of two in the whole state here as a cardiologist who represents the community. And these are my family members. I tell people I love on them, and I'm here to expand my footprint in the state so we can save more limbs and more lives. But what's more pressing for me now is something that I want people to realize and to Google if they can, or look up. It's called the Amputation, Reduction, and Compassion Act, ARC Act, ARC Act. And what that is that, we have lobbied and testified with bipartisan congressional effort to start what we call the PED caucus. And it's stakeholders whose mission are to do the following. One, to help raise awareness for peripheral arterial disease. Two is for HHS to create an educational program and fund it so that rural areas such as Mississippi, Alabama, Louisiana, Arkansas, Georgia, Carolina, you name it, will have dollars that are focused to go in and engage this community, empower them, and help screen these patients at no cost. So they should share no cost. If you're Medicare, Medicaid, or commercial, you should be screened if you're considered at risk for PAD. So that the government should help fund that. And three, they should disallow reimbursements for patients who are just, unnecessarily amputated without some appropriate form of arterial testing, at least 3 months before their amputation. And lastly is to have some kind of quality measure to see how the program is going all through HHS. So it's called the Amputation, Reduction, and Compassion Act. Shout out to Congressman Donald Payne Jr., based out in New Jersey, and other supporters of this bill. Was introduced to legislation, and people should look out to that because we want to have that passed. So you need to encourage your legislators and your local representatives to sign on to be sponsors of this act so that we can prevent the most preventable, the most chronic, the most deadly epidemic that has basically plagued the African American community that most of us are basically unaware of. So that's what's pressing for me, short term and also long term.
Absolutely. Well, we're going to get to some of the questions. That was incredible. I asked what's next for you, and you went to getting everybody to be an advocate for everybody. So that is powerful. So I'm going to put some of these on the screen here. This is from I think it's Deanna Wright. How is circulation in the extremities checked? Does this also pertain to the fingers and hands?
Thank you, Deanna. Yeah, so it's checked by one. You can either have the first by palpation. Fingers are checked on the pulse, and same thing with the hands. Two, the ankle brachial index is basically a procedure where blood pressure cuff is used to assess the circulation in your ankle, compare it to your brachial, which is your arm. And three, ultrasounds or a CT scan can also determine that. Does it pertain to the arms? Yes, it does, but particularly in a population, especially your dialysis populations, people who have chronic kidney disease, people who are older, where the narrowing of the arteries around their neck can happen, they can have issues with circulation in their arms. So that too can manifest.
Okay, here's another one. Other than seeing a vascular physician, is seeing a cardiologist needed regarding circulation issues or concerns?
Yes, because if you were to have circulation, and it's called polyvascular disease, and they're like brothers and sisters. So if you have circulation in one part of your body, the systems, their networks, they work in concert. So if you have poor circulation in your lower extremities, your 60 to 80% of the time might have a blockage in your heart. So that's why we do a stress test on these patients, and we do an ultrasound of their heart to make sure that they have good functioning hearts and good circulation in their hearts. Also, in instituting medicines early on to treat that atherosclerosis in your legs, you're also preventing the progression of plaque in your heart and also in your brain. So you decrease heart attack rates and stroke rates. So it's basically being proactive, but also identifying the fact that these are systems that work in concert. And in treating one, you're treating all.
Okay, let's hear. What other exams are needed other than the various sonograms to detect circulation issues in the legs and or feet?
As I've stated, ankle brachial index exam is something that you can ask for. It's called an ABI. That's their abbreviated form. You can have an ultrasound, which is a sonogram of the arteries. You can have a CT scan or MRI of the vessel. But that all depends on what the need is from a vascular standpoint. And if you do have a blockage that needs to be further evaluated, an angiogram, which is basically what I described, where an X-ray with imaging and using a special agent to look at the circulation through your body, particularly in looking at the anatomical tree of your lower extremities, would be able to let that specialist identify exactly where the blockages are and how to go and tackle that problem.
So what, and there was a question earlier, I can't find it specifically, but it was a question about diet. And I know when people hear that term, diet, let's change it. Let's say your nutrition.
Yeah, okay.
Eating habits. So because when you hear diet, you think about, oh, I got to take this out, do that, whatever. Would a plant-based or vegan diet be, and I'm paraphrasing what the question was, would a plant-based vegan diet be better for your heart versus other kind of more integrated diets?
Yeah, so they've looked at this, and no offense to anyone out there, because people are very particular about their diet. It's like the beehive versus versus Cardi B. Here's all I'm going to say. As a cardiologist and the body that regulates my licensure and accreditation, right? The Mediterranean diet has been shown to be the best, in addition to a plant-based diet. They work great, and for anyone who's looking for more in that, I also sit on the advisory board for Men's Health magazine, so we've recently talked about that. But it's just combination of the Mediterranean and also the plant-based diet. But for those who have high blood pressure, there's something called a DASH diet, DASH, that is basically a low-salt diet. So those are the only 3 diets I'm allowed to technically speak of, okay? Anyone else who has any concerns or any questions about any other dietary plans, I defer to, the experts.
Right.
Let's just keep it there. But the Mediterranean diet and also exercise, and that's the important part. We need to exercise, but it's not just, I walk the dog to Walmart and I come back. Like, no, like you have to go out there and do something, moderate activity, something intense, right? And you have to do that for 150 minutes a week and be committed to it. But it's a discipline. But you have to realize that, and this is to other budding medical students and providers, nurse practitioners and nurses, just because a patient is obese doesn't mean that you sit there in your white coats and you say, well, you know what, go lose weight. That's your solution. No, because here's the problem. These patients have other issues. It could be circulation issues that prevents them from walking, thereby they can't lose weight. It could be because they have high pressures in their lungs, pulmonary hypertension, or they have sleep apnea. And so they can't get that good oxygen exchange. Therefore, they can't exercise and lose weight and lose that sugar that is causing them to become a poorly controlled diabetic. There are things in play other than just labeling them or mislabeling them as non-compliant, particularly those of color. Right. So there's something that's lacking in our in our medical community is compassion. Yep. It's easy to empathize with people, but what action are you willing to take and be compassionate to lead to great outcomes? And that's what we need to start doing and start teaching. And so we do that here, and that's what's what you call loving on your patients. You have to accept the good, the bad, and the ugly. It's what it is, but you have to treat them like your family members.
Well, the unfortunate reality is that Black patients tend to be more adherent to treatment plans when their doctor is Black, and there's not a lot of Black doctors. There's only about 5% of medical practice doctors that are Black, and so you can't see us all. You're there in Mississippi, and people are asking for your contact information because it's like they're gonna make a trip to Mississippi to see you.
Come to the SIP. Let them come to the SIP. Great organization. Yeah. So a great organization that takes care of all my patients is mymississippihope.org. They can reach out to them. But to ask questions, it's padadvocate@gmail.com. That's where and especially those who, you will not believe, Mr. Ellis, how many patients will contact me and say, well, they're about to take off my limb tomorrow. Wow. And so we need to now use the network of endovascular specialists that we are, it's a small community. We all know each other, and find who's closest to that person and see if they can help that patient out. That's what we do. It's not everyone has to come to Mississippi. It's what we can do and the megaphone and the voice we have to either advocate on their behalf. But unfortunately, we can't save them all. And so we need to do a better job from a policy standpoint, because, as Martin Luther King said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. Not only that, but we have to institute judicial decrees, not to change people's hearts, but to restrain the heartless. And that's our mission.
Man, and that's what we do at Black Doctor. Do a little quick shameless plug. If you have any questions, we have a whole kind of heart disease, heart health section on our website. Go there. Dr. Fakorene's article is on there. The video, everything is on there. And so that's what we try to do, try to provide the most up-to-date, relevant information so you can get it, so you'll at least be armed with the information. So when you do go see your doctor, you're better equipped to be able to advocate for yourself or your family member if you're there standing in the gap for an elderly parent or somebody as well. So please understand, being an advocate for yourself and your family member is most important when you're out there. You can't just accept what the doctor tells you. Get a second opinion. If you don't feel right with what they're telling you, get a second opinion. Reach out to PhD Advocate. Find other avenues. Go to Black Doctor. Whatever. Just don't accept. If you don't feel comfortable with the first treatment plan set, go see if that treatment plan is what somebody else will do that makes you feel more comfortable, and get all the information so you are comfortable before you start engaging in any type of treatment plan. So that's my one soapbox statement. So, a lot of words with Dr. Fakorene. This has been fun. This has been fun.
Let's do it again.
Any final words for our audience?
Yeah, it's first of all, thank you all for sharing the last hour with us. We trying to inform to transform. I always tell my patients that your first line of contact in medicine determines if you live or if you die. And so, that is something that is powerful when you read this back or you look back at the transcript or you watch it. Some of these tidbits are important, but ultimately, just remember that ultimately we have control, we have power. 80% of cardiovascular deaths are preventable if we start taking on those steps early on. We not only have to target our older population, we have to go back to our schools, middle schools, high schools. We have to target them. What they eat in schools are important. What they feed our kids are important. What our kids come home to eat are important. And how we engage them in community events early on, and then how that progresses through college and advanced stages. So it's a continuum. We're here to serve. We carried this apron of humility, and we're servants for y'all. So just utilize the platform that we're given to answer any questions, and much love. Peace out from the ship.
I want to say thank you to Dr. Fakorene. This has been a wonderful. It's been fun. It's been informative. Really, really just want to thank you all. I want to thank our sponsor, Boston Scientific, for sponsoring this and getting some great information out there. I want to make sure that you recognize you got to be your own best health advocate. You got to advocate for yourself and for others. Make sure, and one of the things that Dr. Michael Lenore, past president of the NMA, he says all the time, your health is your greatest asset, so please protect it. Please.
Yes, he does. That's a great man, a great visionary.
Yes. So thank you all for joining us on this afternoon. Wonderful. Dr. Fakorene has been wonderful. All his information is there. We're going to do a replay of this Facebook Live later on this week, so we can get more people the information that they need to save their lives and their limbs. So thank you again for joining us, and y'all have a nice day.